Hello, everyone. Today we have a case of membranous nephropathy, an interesting, challenging case. She is a 34-year-old who was referred for a new onset leg edema and proteinuria of 3 plus protein in her urine analysis. She denied any recent history of infection, joint pain, or new rash. Physical examination, blood pressure was 122/72. She had plus 2 pedal edema. Laboratory testing showed serum creatinine of 0.8, serum albumin 3 grams, and urine protein creatinine ratio of 6.8 gram per gram of creatinine. The antiphospholipase A2 receptor antibody was high at a titer of 185. She was up to date on her age-appropriate cancer screen. Her ANA hepatitis panel for both hepatitis B, HIV, and hepatitis C were negative. Complement levels were within normal. She was initiated on supportive care for her nephrotic syndrome with RAS inhibitors, diuretics, sodium restrictions, and statins. Kidney biopsy was performed and showed stage 2 membranous nephropathy with a strong staining for antiphospholipase A2 receptor antibody. Repeat BLA2 receptor antibody showed the titer increased to 312 after 3 months of conservative therapy, and her urine protein creatinine ratio increased to 9.8 grams. And the question is, what do you recommend now? So now the patient has a history of 3 months of membranous nephropathy that was treated conservatively. So do you want to watch her to complete 6 months of follow-up to see if the urine protein creatinine ratio goes down to 4 grams? Or do you want to initiate immunosuppressive medications because spontaneous remission is unlikely? Or do you want to repeat the kidney biopsy to assess the progression of membranous nephropathy from stage 2 to stage 3? Or do you want to do multiple myeloma workup to exclude monoclonal gammopathy? Or do you want to order thrombospondin type 1 domain containing 7A antibody to test for this potential target antigen? What would you recommend now? And the right answer is we need to initiate immunosuppressive medications because after this 3 months of conservative therapy, the patient is progressing and the antiphospholipase antibody level is going up. So the patient did not respond appropriately to conservative management. And now there is immunological relapse. So clinical remission is unlikely because clinical remission is usually preceded by immunological remission. So the patient now has nephrotic syndrome with worsening of proteinuria and phospholipase A2 receptor antibody. So initiation of immunosuppression is warranted. Spontaneous remission with significant reduction of proteinuria is unlikely at that time without intervention. There is no need to repeat the kidney biopsy now because the patient already have stage 2 membranous nephropathy that is progressing with worsening proteinuria, and a repeat biopsy is not going to change the plan for now because we have the evidence non-invasively by using the non-invasive biomarker, the anti-BLAR antibody. There is no evidence of any monoclonal gammopathy in the kidney biopsy, so there is no need to check for multiple myeloma in such case. The thrombospondin type 1 domain containing 7A is a podocyte protein that is identified as a target antigen. So it's a de novo immune complex formation. The antigen, the autoantigen is in the podocyte, and the antigen-antibody complex just, formed de novo in the podocyte. Autoantibodies against the thrombospondin type 1 domain accounts for 1 to 3% of membranous nephropathy cases in Western countries. So it's a small minority, and overexpression of this antibody was found also in secondary cases as malignancies and drug-induced cases. So it's not peculiar to idiopathic forms of membranous nephropathy. Um, Examining the antithrombospondin type 1 domain containing 7A antibody will not add clinical benefit in this patient, although immunosuppression with alkylating agents, so with steroids and cyclophosphamide, or with calcineurin inhibitor used to be the primary therapy for idiopathic membranous nephropathy. Nowadays, we have more and more observational and randomized controlled trial that showed the non-inferiority and some showed superiority of using the B-cell depleting agent rituximab. So now rituximab has been moved as a forefront therapy for primary membranous nephropathy. Thank you so much for your attendance. And here is the reference for this case. This was published in the American Journal of Kidney Disease 2021.